Faster than a speeding bullet.
I ran until my muscles burned and my veins pumped battery acid.
More powerful than a locomotive.
An idea is like a virus. Resilient. Highly contagious.
Able to leap tall buildings in a single bound.
Hey guys, Jared Moon here, and welcome to the Better Humanology podcast. This week we have Dr. Lindsey Lepley, and she is at the University of Connecticut. She's assistant professor in the Department of Kinesiology. Now, Dr. Lepley's research interests center around examining the negative neuromuscular effects of traumatic joint injury and identifying therapeutic approaches capable of combating neuromuscular dysfunction. So that sounds kind of crazy, maybe a mouthful for some of you listening, but man, it was really fun to do this interview with Dr. Lepley because we get into a lot of cool stuff about your joints and how to protect them and how to make sure that you're not only healthy right now in your training, but that you keep your joints and you keep your body healthy and moving properly, all the way into the future, later years in life. And she's doing a lot of research around ACL tears and reconstruction and things like that. And it applies in a lot of different areas. So what we end up talking about is eccentric training. We talk a little bit about blood flow restriction training and a lot of different areas. And she's super smart, has a lot of great information. So listen to this one if you want to kind of bulletproof your joints and be a better human in the process. So without any further ado, here is Dr. Lepley. All right, Dr. Lepley, I'm excited to have you on the Better Humanology podcast. Welcome.
Yeah, thanks so much for the opportunity.
Yeah, it's going to be a lot of fun. I'm excited to jump into a few different topics today. But before we do, I want to talk challenges. So I'm going to throw that to you. If you could give everyone listening a fitness challenge this week.
So my fitness challenge is finding time to sort of carve fitness into the daily schedule. So for me, it's finding time to sort of unplug from everything and go on things like a trail run.
Awesome. Unplug. So no device, nothing, just in nature. I love it.
In nature, trail run. Yep, exactly.
Awesome. All right. How about a mental toughness challenge?
I think it's about like setting up your day and having sort of good intentions for the day. I try to actually, when I shower, I sort of try to visualize my day and the tasks that I need to accomplish and sort of have good thoughts going forward.
Okay. Yeah, I like that. That's a good daily practice. That makes your day very intentional. Not not like just it happening to you, which can happen from time to time. But I like that. All right. How about a book recommendation? Now, this can be anything from, I don't know, an impactful book in your life to something you read recently.
Yeah. So a book that I read recently, it's called Deep Work. It's by Cal Newport. And it's essentially, it's focused around finding time in your work schedule to sort of really drill down and unplug from everything and being able to sort of actually get your work done without outside distractions, and giving yourself sort of a break from technology so you can actually get sort of real work done.
I like that. Do you find like a lot of distraction in your day-to-day work?
I think so. I think, constantly sort of being plugged in leads to sort of a 24/7 work cycle. And, the want to sort of answer people immediately via text, via email, whatever it may be, it sort of interrupts like maybe some of the deeper thinking that you need to do to sort of get your job done right. So you're constantly sort of surface level thinking. So I think this book is a pretty good, gives some pretty good recommendations for like unplugging and sort of finding time to drill through maybe components of your work or life that deserve maybe more time and attention.
Okay, awesome. I love that. I think I'm gonna add that to the top of my list. I like the premise of the book already. So
it's cool.
I'm gonna check it out. Okay, well let's get into your background a little bit. You can take us as far back as you need to, or you would like to, and then up to today, and what you're most passionate about and excited about working on today.
Sure. So my background, so I'm an athletic trainer. I got my undergraduate degree at Grand Valley State University, and then I went on to the University of Virginia and got a master's in sports medicine. At that point, I stopped sort of working clinically, meaning I wasn't necessarily interacting with outpatient orthopedic patients anymore, athletes. I decided to pursue more of a research route that's sort of centered around strength. And the reason for that is I found that oftentimes when I was treating my patients clinically, I would be doing some sort of treatment for X amount of time because that's how insurance reimbursed you. And everything sort of became cookie cutter, and I just really wasn't a fan of that. And what I wanted to do was sort of change it up and say, you know, are there different types of therapies, different types of exercises, strength training that our patients or our athletes could be doing that could sort of optimize results that aren't necessarily based on like a pre-programmed recipe for everyone. And so that sort of drove me to go back and be someone that sort of creates that literature. So then I went on to the University of Michigan and got a PhD in kinesiology there. And I primarily worked in the clinic with folks that had suffered major knee joint injuries and trying to find ways to help them recover their strength that are different than the current standard of care. And then from the University of Michigan, I went on to the University of Kentucky and did a postdoc and sort of shifted focus a little bit there, looking at muscle sort of more in depth. And then since 2015, I've been an assistant professor at UConn, running a couple of labs looking at muscle recovery after injury.
Okay, awesome. And what kind of research are you currently involved in?
Yeah, so my lab has two different sides. We have a side where we run a full-blown human lab where we look at people that have had major joint injuries. Specifically, we typically focus on the knee and ACL injuries. And we look at sort of how the muscle changes after an ACL injury as a model of joint injury, and then also different types of rehab that can help people optimize muscle health after that joint injury. And the motivation behind that is ACL surgery itself, and a lot of joint surgeries don't prevent early onset osteoarthritis. So you can sort of fix the joint, but it doesn't promote sort of long-term health. What we do know is if you can promote muscle health, that can sort of save the joint. So our goal in our lab is to say, like, muscle is modifiable, muscle is something that people can work on, that clinicians can work on without surgery. What can we be doing to improve muscle recovery to promote sort of long-term health and deter maybe joint degeneration? Okay. So that's one side of the house. And then the other side of the house, we work with rodents, we work with rats.
Okay.
And we basically perform the same type of experiments in rats that we do humans. In particular, we cause a lot of rat ACL injuries. Yeah. And the reason for that is you can control the entire environment, and then we can also sort of look at muscle on a more basic level there, and see sort of what's going on after those types of injuries.
That's very cool. And, I'm excited to kind of talk about this a little bit more. Just so we can catch everyone up to speed on basics of ACL injury, what are the primary way people are running into ACL problems that you see?
Yeah, so ACL injury, it's an injury that generally happens to sort of like a younger population. 16, I think, is the peak age. A lot of times it happens in a non-contact way. So somebody could be like running down a court on a field, and they decelerate in a way that their knee sort of moves out of typical motion, and it causes stress on that ligament and it ruptures. The problem with that ligament rupturing is that the stability of your knee joint is really sort of compromised at that point. So oftentimes people seek surgery to fix that. The problem with the surgery and the rehab as it stands is, we talked about a little bit earlier, but generally people don't recover muscle as well after that surgery than they do before. And there's some long-term consequences with having sort of early onset joint degeneration. So people end up having sort of a lifetime worth of knee issues based on an injury that they sustained in their youth.
And so are you looking at also preventative care then, something people could do before, like possibly just to not get the ACL injury altogether?
My lab does not do that. I have a lot of colleagues that try to prevent the initial ACL injury. We're focused on the group of people that have the injury and saying, okay, you've had it. Now what can we do to sort of optimize your health going forward?
Right. And I know a lot of people, a lot of friends and athletes with torn ACLs over the years. And what would happen, it always seemed to be this way, is that, I'd be playing sports with people and they would be it wouldn't even be our sport. We'd play football or something, and then we would go play a pickup game of basketball or something, and then, friend tears an ACL during something like that. It was never like, in my experience at least, it was never the sport that caused it. It was always some random activity. And a lot of the ones I did see, you mentioned court, it was always court sports that did it most of the time in my limited, I'm obviously not collecting data, just talking about friends and athletes of people I've been around. It was always some sort of court sport that seemed to jack with people. And so do you think that surgery, is the way to go for fixing the ACL injury, and then after the fact, that's what you're primarily focused on is, okay, we got a post-op, this is what we should be doing?
Yeah, I think it depends on the patient's goals. And some people are classified as what we call copers. So some people do really well when they're ACL deficient and their knee sort of, with their muscles acting, it self-stabilizes. So some people are okay without an ACL and they do just fine.
Wow.
Other people, it doesn't sort of work out for them that way, and they need sort of the reinforcement of that static stability of that ligament. So pursuing sort of surgery for them is a better option. So I think maybe where it's headed is not everybody needs surgery, and identifying if you're a person that can sort of self-stabilize versus not maybe is something that, future medicine and medical treatment could consider. But we're really on the side of house of, you've had the injury, now what can we do to sort of save the joint long-term and sort of optimize better quality of life?
Yeah, so let's jump into that. What are some of the things that you are having people do to save the joint, for that prolonged period of time? And I'm sure you're talking like well into their later years, you want them to have, good movement of that joint.
Exactly. One of the topics that our lab is really hot on, it's called eccentric exercise. So for your listeners, eccentric exercise is basically anytime you load the muscle while it's lengthening. So if we're thinking about the quad muscle or the thigh muscle, when you're going down into a squat, your thigh muscle is lengthening. There's a load on it. It's considered an eccentric exercise. Basically, most of the exercises that people do right now in rehab are very concentrically focused, meaning that you're like lifting the muscle up. Or lifting the weight up and your muscles constantly shortening. And this is good. And we're not saying that people shouldn't be doing that, but there's sort of been a notion in the literature, which I think has seeped into the clinic, that anytime you lengthen your muscle and you put a load on it, that it's dangerous. But our lab is trying to sort of change that storyline. And we have some pretty basic scientific data and some good promising clinical data to show that if you load the thigh muscle while it's lengthening, you get some pretty good return. Your neural activity looks better, which is compromised after major injuries. It seems to help promote muscle growth much better than a shortening exercise. So it looks pretty promising. And then the other point to it is it's free and it doesn't need any type of specialized equipment. So being sort of purposeful about how you're overloading the muscle and in what sort of range, we think that there's something to that. And that's sort of one of the topics that our lab is pretty hot on.
That's awesome. And how are you guys doing that primarily? How are you introducing eccentric exercise? I could throw a few examples, but I'm sure you got it nailed down.
Yeah, so we do it a bunch of different ways. When we are like running a study, we do it in a very controlled manner. So, we can control all the environment. But you could simply do a recumbent leg press. And let's say your right leg is injured. So you push up with 2, which would be the concentric phase, your muscle shortening. You push up with your right and your left, but then you just lower back down with your right. That would be considered
Got it.
An eccentric exercise. Walking downhill, if you have a treadmill that can do retrograde walking. Walking downhill is your muscles lengthened, and that's considered eccentric sort of loading. You could do single leg squats, and you're in a standing position and you're just lowering down on the limb that's affected. That would also be considered eccentric exercise. So there's a lot of different ways that I think that you can MacGyver movements that you're probably doing in the clinic anyways, but be more focused on sort of the downward motion when you're loading the quad. That would put you into the eccentric category.
Okay, and how long are you seeing it to take effect or for results?
If we're specifically talking about ACL people, we've had some pretty promising results where if people just train twice a week for 6 to 8 weeks, about 12 treatments, they have sort of long-lasting gains in strength that correlate to better movement later on in therapy.
Okay, awesome.
So it's really it doesn't seem to be too time invasive.
Yeah, and it's like you said, it's kind of like intermittent fasting. It's like some of the stuff that you're already doing. You just eat during a certain window. It doesn't cost you anything, and it's like what you're saying with this is like you just move the weight in a little bit different way, a little bit slower, maybe tempo or pause or whatever, and you're completely changed the game and how you're affecting your joint. Now, do you think that this is something to be said for overall joint health, and no matter what joint we're talking about, like more eccentric movement should be included in people's training?
I think in general, I think people avoid this type of movement because oftentimes people get what's called DOMS, delayed onset muscle soreness, when you start doing an eccentric protocol. And so for the first, 24, 48 hours, you're pretty sore. And so people sort of avoid this type of movement. And I think traditionally people have associated this soreness with maybe damage. But the point is that you can do nothing. And after the 48 hours have passed, your muscle is just fine. So, there's no treatment necessary. Your muscle recovers. So that would indicate to us that there is no damage, and maybe it's a good sort of inflammatory response that's helping to build muscle or signaling to the body that look, we need to change a little bit because, this person's taking on a different type of strengthening program. Therefore, we need to build muscle here. So I think people avoid it generally, one, because there's a lot of literature to show that it's damaging. But this has been done in animal models where the muscle has been physiologically changed, so it's no longer clinically translatable, but it's been seeped into the clinic. And then the other thing I think is that people get delayed onset muscle soreness. But like I said, it's self-rectifying. And if it goes away and within 48 hours by itself, that's not damage that's happening there. So I think people kind of need to push through maybe that initial sort of soreness phase and stick with it, because I think you can get pretty good results from it. Aside from building muscle, we have some pretty promising data to show that after major sort of joint injuries and even just a simple ankle sprain, people are showing now that their brain changes, and the brain changes in the way that it tells you to sort of operate your lower extremity. And we're finding that if we give people eccentric exercise, it targets areas of the brain that are sort of changed after injury. So not only may you be doing your muscle a favor, but from a nervous system perspective, you may be giving yourself a very good sort of neural boost and sort of retraining the system that way, which we think is pretty cool as well.
That's very cool. And I will say, my first introduction to any sort of eccentric movement was back when I used to do bodybuilding style workouts, like chest and all that. And we would load up on the bench press, way more than I could lift. My buddy would, I would control the down. He would help me up. And you do get incredibly sore from that type of movement, but it is very beneficial, especially in the muscle growth world. And that's what I was going to ask, because we kind of got to the point that, okay, eccentric muscle contractions are going to help, but what's the real reason behind it? And you're saying muscle growth, and then also neuromuscular, coordination or activity is those are the two primary factors behind the eccentric muscle contractions helping?
Yeah, at the sort of most basic level, the word eccentric is it means odd. And the reason that eccentric exercise is named that way is for a very long time, we've understood how muscle works when it's shortening, but people have not understood how muscle works when it's lengthening. So the word eccentric is actually like a word to describe that we don't even understand at sort of the most basic level, how muscle works. And what we found in the last couple of years, and this is pretty new scientific evidence, is that there's portions of muscle that are very springy. And when you lengthen the muscle, they get straightened out. It's called titin. It's a big protein. It's very springy. And when titin's involved and it's straightened out during an eccentric contraction, it opens up gateways that signal to the body to produce muscle, protein synthesis to produce more muscle that don't get opened up when you're shortening the muscle. So it's like If you lengthen the muscle, it stretches out protein and it opens the muscle up and signals to the body, hey, I need some more muscle here. And so it's sort of a very unique way to build muscle that doesn't necessarily become available to you if you're just using shortening exercises all the time. And this is pretty sort of new evidence, but it explains a lot.
That's pretty fascinating. So
yeah.
Muscle lengthens, and then basically it's like, hey, it signals to the brain, we need more muscle over here from the proteins that are being generated. That's how the body picks up on it.
There's certainly signaling going to the brain to sort of maybe help to sort of neurally rewire it, but there's also signaling basically at like the biomarker level to say, look, there's a need to build more muscle here. So let's put more muscle in. That's
awesome. Okay, now how would you, and I want to talk a little bit more about the brain, but how would you recommend people get started with eccentric lifting?
Yeah, so the current recommendation is if people know what their 1 rep max is, basically you need to overload about 60% of your 1 rep max. We give people a pain scale of 0 to 10, 10 being like, please amputate. You don't want to be working near a 10. You want to be probably working more in like the 5, 6 range in terms of intensity. Getting muscle soreness is one thing, but being able to differentiate between muscle soreness and like actual pain, that's sort of something that your listeners sort of need to be keyed into, right? If pain is coming from inside the joint itself, there's probably something going on with the way that you're lifting the weights, or that there's too much, or the speed is too intense, because you shouldn't really be having pain, joint line pain. You should be having more like fatigue and muscle soreness and sort of those types of symptoms when you're doing eccentrics. Big key things, though, are making sure that you have whatever range of motion you're working through, that it's controlled, that the speed isn't overly intense. And those are some of the bigger parameters to when you start an eccentric protocol. And then once you sort of get comfortable, you can start more with a bigger overload, and that will continue to help sort of produce more gains. Okay.
And you think primarily through machine-based lifting would probably be the safest way to execute, or what do you think?
I think if you're a total novice, then maybe, because it has discrete endpoints where you can't like overextend a muscle or a joint with machines. So that's kind of nice. I think that free weights are always nice because it's going to challenge the system a little bit more. So that's always a good route too, but maybe that's once you make sure that you have sort of the motion down.
Okay. Awesome. Now I do want to go back to that topic. You just mentioned people spraining their ankle and then their brain basically acting differently. And I think that I would love to read more about it, but I think when people get an injury or something, they can start to mess up their whole body, through compensation and all these other things. So can you just talk about that concept a little bit more, and maybe something people should look out for?
Yeah. So essentially, anytime that you have a joint injury, there's sort of going to be a change in neural activity that's going up to the system. And that change in neural activity at some point is going to cause a change in the way that the brain is going to operate. And so what we're starting to see with better sort of imaging technologies is that the way that people decide to move their ankle or their knee after a major injury, different regions of the brain are sort of lighting up. In people that have had ACL injury, it appears that they rely more on their visual system. So they're not getting the information from their joint anymore to say, hey, this is where my knee is in time and space. They need to physically look down to see is where my knee is in time and space. So they have a lot more information that's sort of being regulated to vision centers in the brain, because that's what they need to be successful. So those are the types of examples. So if people feel like things are very different after injuries, there's a lot of evidence to suggest, that in fact is the case. And everything's a chain. So if you have an ankle injury, right, there's going to be a resultant sort of effect on the knee, which is going to move its way up to the hip, lower back, and sort of all the way up. So because it's all connected, there's sort of a direct effect through the entire chain that you need to consider.
Yeah, that's very interesting. Just that research in general, very cool. What kind of, this is like getting way into the weeds, but what kind of imaging do you use to be able to see stuff like that?
Yeah, so functional magnetic resonance imaging. So basically, you have people lay in an MRI scanner, and you use some different types of protocols that basically can look and see where blood flow is going. So you have somebody perform some sort of activity of interest, like a knee contraction, a quad contraction, and you can see in somebody that's maybe had an ACL injury versus a healthy person that they're basically activating different parts of their brain because there's a bigger blood flow to different parts of their brain compared to somebody that hasn't.
Okay, that's really cool. Now, I want to ask, just out of curiosity, have you, in any of your research or I'd say just over your career, messed around with or experimented with blood flow restriction training at all?
Yeah, I'm glad you brought that up. I have not personally used it yet. I think it does have some pretty promising results. And actually, when we go and give talks, I sort of give like a wink in this direction. I think that, it may have some merit. The nice thing about blood flow restriction training is you can train at a much lower intensity and still get the same bang for your buck. So when we talked about eccentrics earlier, we said like 60% of your 1 rep max.
Mm-hmm.
Some of the blood flow restriction training suggests that you could train at like 20%.
Right.
30%. So the thinking that we have, and I have no data to directly support this, is that what if you did eccentrics with blood flow restriction training?
Yeah, better.
Could you
like 24 hours?
Could you? I'm not sure about that. Really, but, could you optimize sort of the neural signaling that you're going to get from eccentric exercise, the direct sort of protein synthesis when you uncoil, tighten, and then also you can train at a lower intensity because you have a restriction cuff on, right?
You're right.
So can you kind of do all of those things? There are some animal models that show that people that have done, the animals that have done blood flow restriction therapy with eccentric exercise under a protocol where it's supposed to cause damage, that the blood flow restriction training mitigates some of that expected damage that you would find. So perhaps it would mitigate some of the DOMs that people see. I don't think there's a lot of data on there out there yet, but I think it may have some merit.
Yeah, I think, just in our conversation talking about muscle growth and connectivity to the brain and all that, it seems like blood flow restriction training is headed in that direction from the conversations I've had about it, at least. And I think very interesting to explore. What I would like to, I guess, kind of ask you from here. So we have muscle growth, because that can happen with blood flow restriction training and eccentric movement. But what about the ligament itself? So we're kind of building up the muscle. Like, what happens to the ligament when we do all this kind of training? Yeah.
So right now, our understanding is if you tear a ligament such as the ACL, it's torn. Ligaments generally do not regenerate themselves, and maybe the biggest sort of downside to that is not only is it like a static piece of tissue that helps sort of maintain joint stability, but it's really dense with neural sort of information. And so when you put a new graft in there, you put a new piece of tissue in there, you're going to get that static stability back, but you're not going to get that sort of piece of the telephone wire that tells you like what's going on in the joint. And so there appears to be sort of long-term, maybe neural compromise because that information is simply lacking.
Okay, interesting. So the majority of the focus after the injury has to be on the muscle.
Yeah, I mean, if you've ever seen anybody recover from major injury like ACL, you will see like in their initial sort of post-operative phases, they can't even recall how to contract, fire their quadriceps muscle. So a lot of early rehab for bigger injuries is just focused on sort of helping your system to rewire itself. How do you actually contract the muscle? There seems to be a pretty big disconnect between what's going on at the joint, what your brain is trying to tell your muscle to do, and what actually happens.
That's awesome. Well, now I want to ask one other thing. So going back to the other part of your lab in rodents and rats, I just would like to hear a little bit more about that. Like, how do you, I don't know, do you just like go, like, how do you,
What are we doing in there?
yeah, I'm just, I think it'd be cool to hear.
Yeah. So, I mean, it's essentially everything that we do with our human subjects, our human patients, we scale down and do with our rodent patients. And it's because, just because we were talking about like what happens when you lose an ACL. Well, I can't invite a human into the lab,
Right.
have them fully intact and then tear their ACL and have a data system collecting at the same time. It just, is not ethical. So that's why we use things like rats, because we have questions that simply cannot be answered. The nice thing about animal work is if we're thinking about muscle is like 99% maintained across species. So whatever I do in a rat muscle at the quad, I would get a similar sort of response, or the anatomy is very similar in a human muscle. And so, like I was talking about earlier, we have a rat treadmill. So, we want humans to walk downhill on treadmills to load their quads eccentrically, while we walk our rats downhill on treadmills to load their quads eccentrically. We have a device that's called the Acl Terrorizer, which non-invasively tears
That's
ACL.
a cool name.
Yeah. It's a colleague of mine, Tim Butterfield at the University of Kentucky, and we developed it together. And it non-invasively tears rat ACL. So that means that it tears an ACL similar to how it would be done in a sporting environment. And what we're using this device to do is to say, okay, what if we expose it to a different type of exercise now? What truly happens neurally? What truly happens from the muscle perspective? What happens at the joint? We can take these joints out at the end of experiments and see, like, did we prevent joint degeneration by giving them, a higher dose of eccentrics than people would typically get? So those are some of the questions that we're sort of asking in that lab. They're not dissimilar than what we ask in humans. They're just kind of scaled in a different manner.
And where do you think, some misnomers are in ACL recovery right now, or just some ways that people could improve? Maybe someone's listening to this has an ACL injury, or, we talked about eccentric, but I'm talking about more like what, maybe something they should avoid doing that it might be common practice.
I'll say sort of I think what the hot topics that are coming forward are, people are recognizing that the brain has changed, which we talked about. So there's sort of this, maybe there needs to be sort of vision retraining. I have a couple of colleagues, Justin Grooms at Ohio University, that's very hot on sort of, maybe if you knock down people's vision and you challenge their vision during rehab, that will help to sort of rewire the network a little bit better. So that would be something that isn't traditionally used in rehab, but could be used. Or some people are advocating maybe virtual reality. Another thing that's sort of hot in the ACL literature right now is people are recognizing that there's a big fear of re-injury when we put these people back to sport. And there's maybe big psychological deficits that are going on. So maybe more comprehensive patient care, not just treating the muscle, the joint, the ligament, but providing, maybe services that can help with overall patient wellness, because these patients have a lot of pain, catastrophizing, kinesiophobia, fear of re-injury, lower self-efficacy. So, we kind of want to build the person up more holistically. And I think maybe seeking out better support services for that is something that is up and coming.
Yeah, I think that's really important. And I know anybody I've encountered who has an ACL injury, that's like one of their biggest fears, is it coming back. And so what do you, and this might be outside your lane, but I mean, what do you recommend people do for that kind of full person concept? Do you think that they should be taught to gain confidence? Like, what do you think that we should be focusing on?
Yeah, so I think that building a support network is pretty key. I think the nice thing about virtual reality is not only maybe it retrain vision, but sometimes people can put themselves back sort of in a fake sporting environment and sort of build up their confidence that way. So when they go back into their real sporting environment and they're trying different types of movements, it's not as foreign to them, or not as like psychologically, or the anxiety, it may be lower. maybe getting sports psychologists more commonly involved in ACL rehabilitation, especially, at the professional level or the collegiate level, certainly seems like it's a route that may be coming down soon.
Awesome. All right. Now, have I missed anything in your current research or anything you're excited about right now?
I think we covered a lot of it. We're excited about sharing some of our work, and we have a lot of data that we're collecting in the lab. So, stay tuned.
That's awesome. And maybe as you get more, we can have you back on. But I'm going to go to the quickfire questions of the show. Are you ready?
Yep.
All right. What's the hardest workout you've ever done?
Oh, probably a preseason workout that I had to do as a soccer player at Grand Valley State. We had terrible Tuesdays.
What'd you do?
I don't know. It was probably just like a lot of sprinting or something at the time, as an experience of which I've blacked out.
Yeah, I've had a few of those myself. Awesome. All right. In your opinion, what's the best activity for building mental toughness?
Best activity for building mental toughness. I think it's just challenging yourself. And just because something's always been done one way doesn't mean it has to be done that way. And sort of seeking out creative ways to solutions. That's kind of what we do in our lab all the time.
Awesome. Now, if you could only have one piece of equipment to train with for the rest of your life, what would it be?
That's a good question. Maybe it'd just be a pair of running shoes to hit the trail.
Awesome. Yeah, that's a good answer. I mean, you're in Connecticut, right? So
yeah.
Lots of trail running there.
Yeah.
All right. Now, the question of the show, what is the best advice you have for becoming a better human? This is 100% open-ended.
I have a quote that I like to follow. It's follow your heart, but take your brain with you. So follow your passions, but make sure that,
logic checks out.
you do some logistical checks from time to time.
I love it. Awesome. Well, where can people go to learn more about you, your research, and everything that you have going on?
So I think Twitter is a pretty good place to follow us. We have a couple of Twitter handles at UConn SOAR, SOAR, Sport Optimization and Rehabilitation Lab. That's a collaborative environment that I work with a bunch of colleagues. We have a lot of our up and coming research there. And then also at Lindsey Lepley would be a good place to check out.
Awesome. Well, Dr. Lepley, I appreciate your time. Thank you so much for being on the Better Humanology podcast. I really appreciate it.
Yeah, of course. Thank you.
Your best. Losers always whine about their best.